Good afternoon, everybody. On, on behalf of Dr. Luxon and the Department of Medicine and my own Division of Infectious Diseases, it is my privilege today to introduce our grand round speaker, Dr. Jospeh Timpone. He's a lifelong Hoya who came to Georgetown in 1985 to get his medical degree and has stayed on to do his residency, fellowship, and then as an attending, except for a very brief detour to be the chief resident at DC General Hospital and a medical officer at the NIH. He's one of those rare physicians who is able to be a superb clinician, a master teacher, and an exemplary researcher. And in being an exemplary researcher, it is also in how he has guided innumerable students in his role as the Associate Dean for Research in the School of Medicine in each student's scholarly project that they have to complete. He has done the same for our residents in his role as the Associate Program Director for Research. As the chair of the Antibiotic Stewardship Program, it truly is his deep intellect that has guided us not only to make the right choice of antibiotics, but how to dose it, how to combine them, while incorporating the microbiological advances that has allowed us at Georgetown at all times to stay one step ahead of the ever-increasing resistant bacteria, viruses, and fungus. Today, Dr. Timpone will speak to us on some new drugs for some bad bugs and some help from our farm team. And please remember that this will qualify for your CME credit for your license. Thank you, and I'll turn it over to Dr. Timpone.
Thank you, Dr. Kumar, for, as always, you give the best introductions in the Department of Medicine, I have to say. Anyway, so as Dr. Kumar mentioned, we are going to try to do a interface between both microbiology and pharmacology and see how really those two arms really have to work in tandem and work together in order to achieve appropriately treated patients. So these are my learning objectives. I don't have any financial disclosures. So what I'd like to do is now, first of all, really just start from the basics. And I think really we have to go to the microbiology lab. And I think what you'll notice throughout my lecture, I know there's some millennials watching this, and there may be a lot of millennials watching this. And in order to keep their attention, I will proudly put a few emojis here and there to just keep you guys all interested. So the first thing I want to talk about is I want to go over the microbiology and really talk to you about what's going on here in our lab. And so you kind of have an understanding when we get lab results, you'll kind of understand what's going on. And I also want to introduce you to kind of the future with regard to our microbiology lab in what we'll be doing probably within, I'm going to say sometime in 2021. I think COVID-19 has kind of changed our ability to adapt this new system. So let's first of all start off and make sure everybody understands what the minimum inhibitory concentration means. So when we talk about the minimum inhibitory concentration, you'll hear me talk about it as the MIC. The MIC is really the way in which we measure antimicrobial resistance. And you'll often see when you get a report back, you'll see something that says it's resistant, and you'll see a number next to it that'll say something like greater than 8, like it'll say, meropenem R, and it'll say greater than 8. That is the MIC that we're looking at. And really, this is a group of numbers that are based from the CLSI, which is basically the lab institute that reviews all antibiotic susceptibility patterns and tries to make clinical meaning from them. So how do we measure an MIC? So that's the first thing. So basically, the MIC really is a process by which we have 10 to the 5 colony-forming units of bacteria, so they're suspended, and you expose it to varying grade levels of antibiotics. And at the point in which you see turbidity, meaning you see growth, that is what we call the MIC. And I'm going to show you this on this next slide. So this slide shows wells E1 through E5. And if you look at this slide, you'll notice that, you know, E1, it'll be approximately 100. Let's say that's the concentration of the drug. E2 is like 50, and then 25 and 12.5 as you go down from left to right. The important thing here is you put a suspension of bacteria, 10 to the 5 colony forming units in all of these wells. You incubate it overnight, and then you look for turbidity. And what you'll notice somewhere between 4 and 5, you know, E4 and E5, you'll notice that there's turbidity. And that's going to be what we define as our MIC. Okay, so that's standard MIC jargon, and then this is exactly what's going on. Now, at Georgetown, and maybe more specifically at our combined lab at Washington Hospital Center, what we do in terms of getting MICs is we actually use an automated system known as the BD Phoenix, shown here. And what the BD Phoenix system does is it actually does perform microbroth dilution, which is basically you know, what the MIC, that's sort of the gold standard for the MIC. And it is able to do this in an automated manner. But notice that when we do this, the turnaround time is about 48 to 72 hours. So just think about it when you're on the wards, you know, you send off a urine culture and, you know, maybe on day 2 hospitalization, you'll see that it's growing E. coli, but probably not until about day 3 or so are you going to see your susceptibilities. And likewise for blood cultures and also sputum cultures. So with this, even with this automated system that really has revolutionized our ability to report susceptibilities, we are still waiting on average about 72 hours. And sometimes, you know, if bacteria don't grow appropriately, it can be even longer than that. And many of you have probably experienced this, that it doesn't always happen as rapidly as we'd like it to happen. So enter what we refer to as sort of our more rapid approach to antimicrobial resistance testing and identification of bacteria. So I'm just going to go to the next slide and just tell you about probably about 3 or 4 years ago, MedStar took on a system which is really known as the Verigene system. And this is a molecular identification system. And I'm just showing you a picture of it here. And let me just go back one slide and just kind of walk you through this. So what this really does is this identifies bacteria using molecular targets. So, and it's a multiplex PCR assay that is performed at all hospital sites throughout the MedStar system. And basically what happens is, if you can imagine, you send off blood cultures to the lab, and the blood culture bottles get placed in the incubator, and then, you know, maybe 12 or 15 hours later, the incubator dings, and basically they pull out the blood culture bottle, and what they'll do is they'll do a gram stain and kind of show you in the way it's going to show up on. Yeah, so the gram stain dings, they do the gram stain, and in MedConnect, you're going to get that initial blood culture result that's going to say gram-positive cocci in clusters. Then by using the Verigene assay, they take an aliquot of blood, send it through the Verigene assay, and then within about 2 to 3 hours, it is able to identify targets. So what'll happen is you might see gram-positive cocci clusters, you know, say at 8 a.m. in the morning while you're pre-rounding, and then at about 10 a.m. when you're rounding with your hospital list, you scroll down and you'll find out that it's actually now been identified as Staphylococcus epidermidis. So that's a pretty rapid approach to identification of bacteria. And it's really unique in that the molecular identification system that we use is with the Verigene is we could see these gram-positive targets. And if you look at this list, this is my wish list for bacteria I need to know when I'm rounding. And so so again, you got all your gram-positive targets. You have all your gram-negative targets too. And again, it doesn't cover every single bacteria, but just think about it. Within a few hours of getting that first gram-positive cocci clusters or gram-negative rods on blood culture smears, you will have an identification. And this is going to help you with your decision regarding treatment. Now, one of the other advantages of the Verigene system is we also will see results of resistant targets. So not only does it give us a rapid ID of the bacteria, but within, again, 2 to 3 hours, it can also identify whether or not specific resistant genes are there. So we might find out that that gram-positive cocci clusters in the morning was identified as Staph aureus. I'm sorry, gram-positive cocci clusters in the morning is present. And within 2 or 3 hours, we may find out that it's Staph aureus, and it might say the MEK-A gene is present. And if it says that, then we know that we have to cover for MRSA. Likewise, it can also pick up resistance for vancomycin resistant enterococcus. So it can also pick up the VAN-A and VAN-B gene. Now, another exciting thing that it can do with our gram-negative panel, though, is not only can it identify something as being Klebsiella or E. coli or Pseudomonas, but it can also tell us about some of the resistance genes. And this would include the gene CTXM1 or CTXM, which is the important gene that is responsible for causing extended spectrum beta lactamase production, or ESBL. You'll hear us talking about it as ESBLs. So this can detect ESBL. So if you have somebody in the morning who is in the blood is growing Klebsiella, and now it says CTXM gene is present, you know that you have to cover for an ESBL. And if you have that patient on a cephalosporin, you need to rapidly change them to a carbapenem. Likewise, it also can detect many of the CRE genes, including the most common one, which we see in the United States, the KPC gene, as well as many other carbapenemase producing genes. One of the other ones that is most notable throughout the world is the NDM1, or the New Delhi metallobeta lactamase. So we're able to get a lot of information. What's great about getting these molecular identifications and these resistance genes, we can then rapidly put these patients on contact isolation. So if somebody is growing Klebsiella pneumonia that has KPC, within a day or so, rather than waiting for 48 or 72 hours, that would be 72 hours without having that patient on isolation. So it can rapidly tell us to put this patient on isolation. So it helps infection prevention. So the next few slides I want to talk about is some new technology that we will be moving towards here throughout the MedStar system. And this is known as the Accelerate Phenotest. And this is just sort of a picture of somebody working over the instrument. And so let me explain how this is different. So this is not a molecular-based or genetic-based assay, but rather this is a rapid phenotypic system. And if you recall back from a few slides ago, I talked about the turnaround time for phenotypic testing. When we get the actual antibiotic susceptibility testing, it takes about 72 hours. Well, this is, in my mind, it's almost like Star Wars to me because it's so rapid the way this happens. But let me just walk you through it. So this is a phenotypic system. And once that blood culture bottle, as I mentioned, in the incubator pops up as being positive, they will then take an aliquot of the blood, and within 1.5 hours, using another system known as fluorescent in situ hybridization, or FISH, they are able to identify targets and identify bacteria that way. So by 1.5 hours, we know an identification. But the more amazing thing is they place, and this is totally automated, so it's a totally automated system, but they actually place this into the system. And the next part of it is it sort of breaks down the red blood cells. It goes kind of through filtering and things like that. They do the FISH identification, you know about that. But then it uses lapsed camera images and generates growth curves. And basically it does this microscopy that takes pictures of bacterial growth every 10 minutes. And then it generates a curve. And I really don't understand the mathematics behind it and actually how they do it. But then those curves are then, they're fitted to what an MIC is. So they expose the bacteria to an antibiotic and they measure the antibiotic growth in real time, generate this curve, and basically you have MICs. And these MICs have been, have been approved by the FDA and all. So it's really quite amazing. And I think, yeah, this next slide kind of just walks you through kind of the flow. So what you have is, you get a positive blood culture, it gets placed into the accelerate phenosystem. And within 1.5 hours, using FISH technology, it identifies the organism. And now look at this, within 7.5 hours, again, using those pictures of bacterial growth, it is able to generate MIC. So by 7.5 hours, so that's within that same day, you will have your antibiotic susceptibility testing. So it's pretty impressive. On this next slide, I merely want to just show you the targets. And again, it's most of the more common gram-positive cocci and gram-negatives. Now, I also want to mention to you that even though we're doing all of this and we're working really hard to do all this, the microbiology lab still does the routine bacterial susceptibility. So we're still doing regular or routine microbiology, but this is kind of the rapid thing. And my hope is that when we use this system, we get our susceptibility, we might be able to rapidly change our antibiotics, de-escalate in a very rapid manner. And this next slide is just a study that was shared with me by the company. And what I think is important, if you look at this, if you look at standard of care versus using the Accelerate Phenotest, you reduce your antibiotic days by about 2, and you also reduce your length of stay by about 3. So this is kind of a new system that we may be going to, and again, because of COVID-19, we don't know, but hopefully within the next several months, we will start using this system. Now, I just want to also mention to you that we also see very resistant bacteria, and the micro lab, this is just the protocol. Don't want to spend a lot of time on this, but if we see a very resistant bacteria, gram-negative rod, the micro team has a flow procedure where they will automatically do, and these are actually manually done, they will perform our Kirby-Bauer disc testing on some of these newer antimicrobial agents. So that's what's going on in the microbiology lab. What I want to do now is, I know all of us, don't really remember a lot of our pharmacology, but I think it's important to understand the microbiology pharmacology interface. So let's talk a little bit about pharm now. So the first thing I want to mention is when we talk about pharmacology of antibiotics, we think about pharmacokinetics, which addresses really absorption, distribution, metabolism, and elimination. But the thing I want to focus on is pharmacodynamics. And I think, we as clinicians don't really appreciate what's going on with pharmacodynamics. But I think the point about pharmacodynamics is if you think of it this way, really, pharmacodynamics is the way really in which antibiotics kill bacteria. And there's really 2 methods of bacterial killing that occur. So there is, first and foremost, there is concentration-dependent pharmacodynamics. So what this tells us is the following, that when you're killing bacteria, so the way in this works is that the higher the dose you give, and then the highest concentration, or the Cmax, you want to push up that Cmax as high as possible, and you want to get it really, really high, the better the kill you get of bacteria. And the other interesting thing is that with pharmacodynamics concentration dependent, what also is interesting is that you could see a post-antibiotic effect, even if the level falls below the minimum inhibitory concentration, or the MIC. So you really are looking for, and the curve really looks something like this. It's really, you get these really good peaks, and then with these really good peaks, you get exceptional killing. And the agents that we do this, that really depend upon pharmacodynamics are the aminoglycosides and the fluoroquinolones, as well as daptomycin. And what's important about all of these, if you just think about it, how do we dose these? And years ago, the aminoglycosides we used to dose every 8 hours. But based on this pharmacodynamic modeling, we've actually realized that you get better killing when you give a big whopping once-a-day dose. So this is really extended interval dosing. And if you think about the aminoglycosides, and our dosing of the quinolones, specifically levofloxacin or moxifloxacin, and dapto, how do we dose them? Once a day. We dose them once a day because we're giving a really high dose and we're getting better bacterial killing. The other type of pharmacodynamic property that is seen with bacterial killing is time-dependent pharmacodynamics, or time-dependent killing. And what this really says is the following, is that what really matters is not how high the dose is or how high the peak is. What really matters is how long you stay above the MIC. And what we really want to do is we want to try to be at least 4 to 5 times higher than the MIC in the bloodstream. And we want to be at that level for about 50% of the dosing interval. Okay, and I think it's going to be shown on this next slide here, a graph of concentration dependent. So, and what's really important about this is, so let me just give you an example. Supposing a bacteria, let's say E. coli, has an MIC of 1, all right? What we want to do is we want to make sure the blood levels stay at a level of about 4 for at least 50% during the dosing interval. So if you dose at 8 a.m. and then dose at, say, 4 p.m., you want to make sure 50% of the time your level is about 4. So it's time above the MIC. And if you go way, way above the MIC, you don't get any better killing. You really just get the best killing when you're at least 50% of the time above the MIC. And then one last thing I do want to mention about this is that in critically ill patients and in patients in the ICU, maybe, and I'm just going to say maybe, there's data to support that perhaps we should stay above the MIC 100% of the time. And so you know, and there's work that's been done on that, but I don't want to go into the details of that. Excuse me. So when we think about this, you know, so what does this all mean when you know, how does it clinically translate? And again, it clinically translates in the way we should be dosing our antibiotics. So again, if we look at the aminoglycosides, you want to do Q-day dosing for your aminoglycosides. And again, I think if you get confused about this, it's really important to call in the pharm team. I think that's kind of the underlying theme of today, that they really can help us. Likewise, for concentration dependent, for time dependent killing, this is another thing that I want to mention that, and I'm sorry, I went through it a little quickly, but the beta-lactams, if you think of all our beta-lactams, whether it be our PIP Tazobactam, Cefepime, Meropenem, all of them are dosed relatively frequently. They're usually Q4, Q6, Q8 hour dosing. So all of your beta-lactams are dosed pretty frequently. And the reason why we want to dose them that way is we're trying to stay above the MIC. Now, one of the ways in which we can improve our pharmacodynamics is if we use slow infusion, meaning instead of giving it over a half hour, you give it over 3 hours. If you give it over 3 hours, you're going to have much better chance of being above that MIC, and hence you're going to get better bacterial killing. And I think on this next slide, this piperacillin tazobactam has been studied very heavily with regard to time-dependent killing. And again, what this slide really shows is that there were better outcomes when they did this prolonged infusion. So again, what we will sometimes do with our bugs that have higher MICs, in order to make sure the drug works, we slow down the infusion. And instead of giving Zosyn like you know, every 8 hours over like just, you know, 1 hour or a half hour, we run it over 3 to 4 hours, and that will guarantee that we'll make it above that MIC. So the last point I want to make in this section is really, I just want to kind of focus on the fact that there are patients in the ICU, physiology is awry. And my point is that, you know, we're dealing with all types of abnormal physiology, and hence our ability to process drugs, excrete drugs, changes dramatically. And it can change dramatically. You know, if somebody is in septic shock, they may have augmented renal clearance. So what I'm going to really say to you all is that when you're dealing with your patients in the ICU, please talk to our pharm team. They're really exceptional at figuring out what appropriate doses are. And I think we tend to underdose patients when they're in septic shock and things like that. And I think we're afraid to do it. But getting a good pharmacologist involved really can go miles. So this next slide really just kind of summarizes what I just said. So I don't want to spend any more time on it. So now, let's just move quickly on to the problem of antimicrobial resistance. And I just really wanted to point out to you this data that came out of the CDC in their 2019 antimicrobial threats report. And basically, they looked at resistant pathogens from 2012 to 2017. And as you can see, they found that there are about 2.8 million patients annually are infected with multi-drug resistant organisms. And you can see that there's about 35,000 deaths annually due to these organisms. And I think our big threat pathogens are our ESBLs, our CRE, our multi-drug resistant Pseudomonas, or our difficult to treat Pseudomonas, and our carbapenem resistant Acinetobacter. This next slide is actually from the New England Journal, and actually this is this report from the CDC, and it shows you 2012 through 2017, and what it shows you here is it really is focusing on the fact that if you look at the bar graphs, one of the things that they do notice is that ESBL, for example, there's about a 53% increase in ESBLs from 2012 to 2017. And what's more important about that is more common in the community. MRSA seemed to have gone down. CRE has been about stable. Okay, so now I want to go back to a really old drug that we need to replug, okay? And this drug is a drug that many of us, before we go to the drug, let's go through the case. So we have a patient, 56-year-old male who is admitted with fevers and back pain, has some medical comorbidities. You obtain an MRI of the back and you find out that he has L4, L5, disc space infection and osteomyelitis, vertebral osteomyelitis. Your blood cultures are growing gram-positive cocci in clusters with the MEK-A gene. And so we know, based on what I said before, this is going to be MRSA. The patient is not obese and has a reasonably good creatinine. And so most of you would say, okay, this is easy. I could probably get away with 1 or 1.25 grams Q12 with this patient. But everything's going to change with this drug, Vancomycin. So you all are aware that vancomycin is a very important agent that we use to treat resistant gram-positive cocci. And it's an old drug, and it was invented by Eli Lilly back in the 1950s. And, we've actually been using vancomycin for 61 years. The sad thing is we really don't know how to dose it even after 61 years. And back in the day, in the 50s, it was referred to as Mississippi mud, and believe it or not, I found this on the internet. I Googled Mississippi mud and vancomycin, and they showed this very old picture of this very old vial. And when I look at it, I just cannot believe that they were infusing this into patients. That being said, there was lots of toxicity due to impurities back in the 1950s, and I think it was abandoned, and I don't know what year it was abandoned, but it came back into favor in the 1970s because of the increased rates of MRSA. And as a result of that, the company actually did some purity improvements to make it almost 95% pure, and it came back on market and everybody was using it. And really, initially people were told you draw a peak, you draw a trough. And then in 2009, people said, there was a group that met, pharmacy, infectious disease pharmacists and IDSA and met and said, you know what? Doing peaks really doesn't predict anything. Let's just focus on troughs of 15 to 20. And that's what we've been targeting. When somebody has a serious MRSA infection, we go for 15 to 20. Well, what has happened since that time is there has been increased rates of nephrotoxicity. And I just have one study there and a comment about another study, really in which, using this target of 15 to 20 as our goal target to treat serious MRSA infections really has resulted in increased rates of nephrotoxicity. And in this one study in critically ill patients where their mean trough level was about 16, there was a very high odds ratio of developing nephrotoxicity. So again, with this aggressive dosing strategy of trying to reach for 15 to 20, we really have, it really has resulted in increased nephrotoxicity. So just recently, I want to point this out to you, is that we have now recognized that using trough levels is actually equivalent, or using aggressive trough levels of 15 to 20 is equivalent with increased rates of nephrotoxicity. So the same group met again, the Infectious Disease Society of America and the American Society of Hospital Systems Pharmacists met. And really, they looked over the data that came out since 2009 and realized, hey, there's a lot more nephrotoxicity. And what they came back to was the following, was that, you know what, the trough level of 15 to 20 is not a good surrogate of drug efficacy or toxicity. And they kind of went back to the drawing board, and they recognized that it is better to look at area under the curve, or AUC, versus MIC ratio. So the AUC to MIC ratio is what's actually going to be used now for future vancomycin dosing. And what this assumes is that the MIC for MRSA for vancomycin is 1, so it makes an assumption. And number 2, what the recommended AUC MIC ratio is 400 to 600. So reaching a level of 400 is going to get you therapeutic. And there's lots of nice studies, both modeling studies, PK modeling studies, as well as actual observational studies where they've looked at it. And I can tell you that I've seen studies, if it's like less than 370, you get less efficacy. So the bottom line is 400 to 600 of this AUC to MIC ratio is really helpful. Now, how do we figure this out? Well, the bottom line is we're probably not going to figure it out. We're going to leave it up to our pharmacists, and it's very likely in the future we will be writing orders like vancomycin to be dosed by pharmacy. And basically what this depends upon is Bayesian modeling and Bayesian software. And what you're going to do is basically patients are going to get a dose of vancomycin, and even with a single dose, like you can do a single level at about 2 hours, you can actually calculate the appropriate dosing for that patient to target an AUC of 400 to 600 with a single dose. Now, the guidelines do recommend that you do 2 doses, one at 2 hours and one at 8 to 12 hours. And the more doses you do, the more accurate you're going to be, but you can actually rapidly come up with the appropriate dosing strategy in a very rapid manner. And this is good because patients, will likely do better with regard to not only bacterial killing, but also with regard to nephrotoxicity. And again, we don't have to wait for steady state levels like we used to. And we're going to be using a Bayesian software known as Insight RX, and MedStar already has a working group. I think by early next year, you'll be seeing and hearing more about this, but I wanted to just call your attention to this, that we've basically been doing it all wrong. And even one of the most respected colleagues in this institution, Dr. Kumar, has even been dosing vancomycin wrong. So the bottom line is we learned a lot over the last several years, and again, I think pharmacologists are really going to step in and help us with this. The only other point I want to make on this slide is that we are also going to likely be giving much higher loading doses, 20 to 35 mg per kg as our initial loading dose. And again, particularly in patients who are critically ill with MRSA, who are in septic shock, those patients, you want to get levels up really high. And again, this is all, stay tuned, this is all to come, but I just wanted to point your attention out there. And again, this guidance document is actually present on the IDSA website. Okay. All right, so now I want to talk about some drugs that I'd like to give hugs to, okay? And Because of the threat of multi-drug resistant organisms, we have had a really rapid influx of new antimicrobial agents in the last 10 years. And I want to just kind of first talk about these drugs, and then I want to talk about how we can best use these drugs. So the first drug I want to talk about is ceftazidime Tazobactam. So this is a cephalosporin, a relatively new cephalosporin. It's also known as Zerbaxa. And it's indicated for complicated urinary tract infections, HAP and VAP, and also complicated intra-abdominal infections when you give it with metronidazole. So what's unique about this drug? So first and foremost, this drug is unique in that it has enhanced activity against Pseudomonas that is actually even improved in the setting of Tazobactam. And so because it has an enhanced activity against Pseudomonas and its activity against Pseudomonas is innately better than all the other cephalosporins, this is really going to be, and I have it in orange here, our go-to drug, our first-line therapy for difficult to treat resistant Pseudomonas or DTR Pseudomonas. It also has activity against our ESBL producing E. coli, Klebsiella, et cetera. Again, good drug, excellent drug for Pseudomonas, but it's not going to cover other resistant organisms like CRE or agents or like carbapenem-resistant Acinetobacter baumannii. And if you look at the table here, I just want to point out that if you have ceftazidime or meropenem resistance, you'll see that ceftazidime Tazobactam will cover in the mid to high 90s susceptibility in those settings. And then for a multi-drug resistance, so this is one that's resistant to many, many classes, it covers about 50%, 57%. So again, I think for our drug, our go-to drug, when we have, resistance to, our pip-tazo, our meropenem, our cefepime, is really going to be ceftazidime Tazobactam. I want to move now on to ceftazidime avibactam, also known as Avicaz. And ceftazidime has been around for a long time, but the avibactam is a beta-lactamase inhibitor that really improves ceftazidim's activity. And the thing I want to point out here is it also has been approved for UTIs, for HAP and VAP, and also for complicated intra-abdominal infections with metronidazole. It covers broad-spectrum gram-negative rods, which include our ESBL producing agents such as E. coli, Klebsiella, et cetera. It also covers Pseudomonas, and probably not as good as ceftazidime. And then really importantly, it covers some of our carbapenem-resistant Enterobacteriaceae, which include our KPCs, or Klebsiella pneumonia, carbapenemases, and OXA48. Again, this drug has really, I think what I want you to remember in orange on this slide, so ceftaz avicaz really now is the preferred agent for treatment of serious infections due to CRE. And this next slide is actually a very small study, but what they did in this study, it was sort of an observational study. They looked at ceftazidime avibactam versus best available therapy. And that best available therapy often included drugs like tigecycline, the aminoglycosides colistin. And the bottom line is that you could see that there was better outcomes with the ceftazidime avicaz treatment. And one thing I want to point out, notice the reduction in nephrotoxicity, 18% versus 30 to 40%, depending upon whether they were on an aminoglycoside or colistin. So again, the older drugs that we were using for CRE are largely being replaced. When we have a CRE infection, now we're really going to avicaz. This is really the drug to go to. Our next drug is meropenem vaborbactam, and meropenem vaborbactam, meropenem you all are familiar with. This drug, covers again gram negatives, Pseudomonas also, but now with vaborbactam it expands its activity. So what's the most important thing about this? So meropenem vaborbactam, you now get not only, we've always been able to be covered by ESBLs, but now you get coverage for CRE. So this is going to be another agent that we're going to be using for CRE. It's only so far been approved for complicated urinary tract infections. And the other point I want to point out here is note the dosing. It's 4 grams every 8 hours. given over 3 hours. What does that tell you? So what the company did is, again, they went back to their pharmacologist and said, if I give this by slow infusion, I'm going to maintain my time above the MIC. So this is always given as a 3-hour infusion, and it's given at very high, maximum doses at a 3-hour infusion. So you're guaranteeing that you're staying above that MIC. And for drugs that are very resistant, I think this is a really important approach. And this is just a study, the Tango 2 trial, that again looked at meropenem versus best available therapy. So I think meropenem vaborbactam, excuse me, specifically meropenem vaborbactam, I think this is an agent. Where would I put this? So I think this is one of the other agents I would consider to use for CRE. One other point I want to make that was on one of my other slides that I kind of skimmed over is one of the things about, let me just go back to, okay, yeah, let me go back to this slide. So I just want to mention that ceftazidime avibactam, actually 10% will develop resistance with treatment. But what's interesting about it, when the BLA KPC gene occurs and you get resistance, the hydrolysis properties of that beta-lactamase actually decreases against the carbapenems. So if you have resistance to ceftazidime avibactam, you can likely salvage the patient with meropenem. And again, perhaps we could use plain old meropenem, but maybe even better, we can use meropenem vaborbactam. Okay, the last new agent I just want to mention quickly is eravacycline. And eravacycline is a new fluorocycline, and actually, again, to get our pharmacology credit, where does it work? Its mechanism of action is at the 30S ribosomal, and it inhibits protein synthesis. It has a very broad spectrum action, gram-positives, including both MRSA and VRE. It also has activity against gram-negatives, but note, it covers ESBLs as well as CRE, and very importantly, it's probably one of the best drugs we have for carbapenem-resistant Acinetobacter baumannii. And again, this has been approved only for complicated intra-abdominal infections, but that being said, we're probably going to do some off-label use, and we're going to likely consider using it for things like CRE, and in particular, I think for carbapenem-resistant Acinetobacter baumannii. Okay, and so what I just want to say is some drugs we need to sweep under the rugs. And again, drugs that you're going to not see us use anymore is colistin and tigecycline. And these are really actually felt to be less favorable now. Colistin due to its nephrotoxicity. And there have even been studies, observational studies, where patients appeared to do worse when they had colistin containing regimens. And tigecycline had an increase in all-cause mortality. So we're not going to be using these drugs anymore. But I do want to mention just a few words about cefiderocol. This drug is not even on our formulary yet, and it just came out recently. And what's unique about it is it's a cephalosporin cytophore. And what it actually does, its mechanism of action is really unique in that it actually scavenges iron. And then what it's able to do, let me show you on this next slide, it scavenges iron from from the environment, from the body space, and it acts as a cytophore. And what it does is it goes through the active iron transport channels of the bacteria. And if you think about it, you have these porin channels on bacteria that can close off and prevent bacteria from entering. But because it's picked up by the bacteria as being a cytophore, it then actually can make its way through this iron transport channel. And within the periplasmic space, it actually dissociates the iron, and then it can go on to bind to the penicillin binding proteins and basically kill the bacteria. It has a very broad spectrum of action, and the point I want to make about it is it's all gram-negatives, and it's really a drug that we're only going to reserve for serious infections due to CRE. It also covers some of our non-lactose fermenting gram-negative rods, specifically Pseudomonas, Cenotrophomonas multifilia, Burkholderia species, and that very resistant Acinetobacter baumannii. So it's going to be a good drug to be used in that setting. But what I wanted to point out is it actually has been approved for complicated urinary tract infections. But unfortunately, there was a trial known as the Credible trial that demonstrated poor outcomes as a result, demonstrated a mortality, an increased mortality with patients on cefiderocol. So again, what I'm going to say about this is because cefiderocol, although it has a great spectrum of action, I think for these resistant gram-negative rods, I think we're going to stick with drugs like Tazobactam, ceftolozane, meropenem, vaborbactam first, and reserve cefiderocol until we have more data on this problem with increased mortality compared to the comparator arm. And again, so I think this is going to really very much be one of our alternative agents. Okay, so I'm going to do a couple of cases and we'll be able to kind of stop. So this is actually a typical day on call. So a patient comes in from a nursing home and is altered, has some fevers. The PGY1 says to the PGY2, you know, I got cultures. PGY2 says, please start the patient on Zovan, which is the combination of Zosyn and Vancomycin that all of our house staff like to use. And this is sort of a text conversation that occurred the next day. The PGY1 says, hey, you know, it's growing Klebsiella pneumonia, CTXM is present. The PGY2 says, how's the patient doing? He says, the patient's doing fine. Okay, let's stay the course. And maybe we should call ID, and then very proud of his intern, and gives a really nice thumbs up emoji, and then goes on and texts ID, and this is what ID says. So as you can see, that wasn't the right answer. And what I want to really reiterate and drive home is that when you see CTXM, it's an extended spectrum beta lactamase. If you see molecularly that an ESBL is present, so you see the CTXM gene on your blood cultures, you know it's an ESBL. Or if you look at your susceptibility and you see resistance to ceftriaxone, that is our surrogate for ESBLs. And you're familiar, really, the most common ESBLs we have are E. coli, Klebsiella pneumoniae, Klebsiella oxytoca, but there's a bunch of others here. And the only point I want to make, again, is I want to just show you that this is the reason why the ID team was so sad. And it really is because if you look at the ID teams, the data that the ID team is very aware of, it's the Mourinho trial that was published in JAMA in 2018. And what they did was they looked at patients who had ceftriaxone resistant, but piperacillin and tazobactam sensitive isolates, and they randomized them to receive either meropenem or piperacillin and tazobactam. And these are patients who had either E. coli or Klebsiella bacteremia. And the study was halted early because basically there was a survival advantage in the carbapenem arm, the meropenem arm. So I think the mortality was about 12% in the pip-tazo arm and about 3% in the carbapenem arm, meropenem arm. And this is just a little bit more about this. So the bottom line is that in terms of what the, I also want to mention this, there's a guidance document that came out just about a month or so ago by the Infectious Disease Society of America. And it actually goes through a bunch of scenarios and what gram-negative agent you need to use for it. So this is really from this document. And the most important thing I want to point out is that this document points to the fact that, number one, it's you want to always, when you have an ESBL, you want to use a carbapenem for anybody who's seriously ill. Number two, for that bloodstream infection or bacteremia, cefepime or pip-tazo, even though they're sensitive, are not recommended, okay? And that's all I want to say about that. Let me go on to the next case. So another kind of similar case, a 79-year-old female from a nursing, from a long-term care facility comes in again with fevers, altered mental status, blood cultures, urine cultures obtained, and you see that you have the presence of ertapenem that is resistant and meropenem that is sensitive. So by definition, according to the CDC, this would be considered a carbapenem-resistant Enterobacteriaceae, and sometimes we're referring to it now as Enterobacterales. So I'll be saying that interchangeably. But if we look at carbapenem resistance can occur in many different mechanisms. Closing off of porin channels, permeability, alterations in proteins of the membrane, drug efflux pump, and carbapenemase production. So not every carbapenem resistant is producing a carbapenemase. That being said, 50% of our carbapenem resistant organisms will be producing a carbapenemase. And really the most important one I want you to be aware of, or two most important, are the KPC, Klebsiella pneumoniae carbapenemase, and the NDM, which is New Delhi metallo-beta-lactamase. And shown on this slide here, you could see that really KPC is the more predominant one in the United States, and then you can see that NDM is seen in Southern Asia as well as in Europe, and Europe has a mixture of both, and there's some oxythrone in there. But I think the point I just want to make is about the KPC. So what do we do for patients with CRE? And I really just want to, I'm going to go over this very, very quickly, and the point I want you to take home is that, first and foremost, if it's ertapenem sensitive, but ertapenem resistant, but meropenem sensitive, like this case, you can still use a carbapenem. But what they recommend is use a carbapenem and take advantage of the pharmacodynamic principle of slow infusion meropenem. So you use it, you infuse it over 3 hours, so you're getting that time above the MIC. Clearly, if both of them are resistant, and if you have what we refer to as a true CRE, which might be with or without KPC or with KPC. In that setting, as I said before, the drugs that we use for CRE, for true CRE, are going to be ceftazidime avibactam, meropenem vaborbactam, or imipenem cilastatin relebactam. And I'm not going to go over that drug, but that's one of the other drugs. And again, this just covers the genetics. So if you have a KPC identified, again, the drugs are the same. If it's if it's a NDM1, and again, this is one that we rarely see here, you might have to use alternative agents. And if you notice in all of these, one of the options for alternative is cefiderocol. Okay, so I'm going to move on really to our, I think this is going to be our last case. Actually, let me just, hold on. Yeah, I want to just go on to this last case. Oh, the only thing I want to say about CRE is I just want to mention that just because it's CRE, you don't necessarily have to treat, for a prolonged period of time. Actually, the guidance document says you don't need to treat, even longer just because it's CRE, as long as you're using one of the active agents. Okay, and this is really our last case. So this is a patient we saw probably about 2 years ago, a 53-year-old male with short gut syndrome who underwent a multivisceral transplant and had a very complicated post-operative course, including a Pseudomonas pneumonia, received carbapenems, and then basically developed a pleural effusion, found to have an empyema, which grew Pseudomonas and gram-negative rods, and this is a non-lactose fermenter, and this is a susceptibility pattern. We presented this at Morning Report, and this is what the ID doctors did, and this is what we often do when we have bugs like this. So now I just want to kind of talk a little bit about, for a few minutes, and I'll be finished with you, is drug-resistant Pseudomonas. So we have multi-drug resistant Pseudomonas, which is actually, it has to be resistant to one agent in any of the three classes, and difficult to treat resistant Pseudomonas or DTR Pseudomonas. And this is basically just pretty much pan-resistant Pseudomonas to all the agents shown here. So all the usual drugs that we would want to use, piptazo, meropenem, cefepime, the fluoroquinolones. This is DTR Pseudomonas. How do we deal with this? So again, the way in which we approach this, number one, is you're going to use, as your initial agent, you're going to use the drug that we really go to is ceftazidime Tazobactam. So remember, that's the drug for difficult to treat Pseudomonas. And again, we may be able to use, as alternatives in this setting, we may be able to use drugs like cefiderocol in the near future. That might be our other option. Okay, so what I just want to mention right now, and this is really, really truly my last case, and because it just brings it home. So we have a, hold on, let me see. Yeah, we have a 28-year-old male, morbidly obese, who gets admitted, who has a history of alcohol use, gets admitted to an outside hospital with acute necrotizing pancreatitis, multi-organ failure, gets transferred to Georgetown, and in Georgetown is ventilated, placed on CVVH. The patient has a very rocky ICU course, including abdominal compartment syndrome. As a result of necrotizing pancreatitis, goes emergently to the emergently to the OR for debridement, and then ultimately has problems with hemorrhagic shock and actually dies from hemorrhage. But as part of the hospital course, and the patient was only at Georgetown for about maybe 2+ weeks at the time, and he received some Zos and received some meropenem, but he grows out CRE, and this is the horrible resistance. And notice it's also resistant to ceftazidime avibactam. And really what I learned from this, and I'm just going to end with this, is that this was a patient who received, I wouldn't say, a lot of antibiotic exposure, like months and months and months, but received a couple of weeks. And probably because of the fact that this patient was critically ill, in septic shock, and also because this patient was morbidly obese, we were probably underdosing the patient. And hence, I really think when you get into scenarios like this, these complicated patients, you really need to call in our farm team. And so this is our farm team that I want to acknowledge Lan Duong, Brian Lindner, and Nicole, who really do exceptional work telling us how to do it. And I want to finally acknowledge all of our, my chief, Dr. Kumar, and my wonderful faculty and fellows who I support. And if you just wait 1 second, I just have one surprise for you, and then I promise I will be over. So I know I went through a lot of stuff, but I also know that you're not going to remember most of the stuff I talked about. So I figure everybody remembers a song, so I'm going to play a song for you now. Honey, don't you touch my carbapenem. Plenty other bugs or them drugs. You choose to use my carbapenem, you're not in love with me, you're stuck with CRE. I heard the same thing happened to Cephalosporin. People thought penicillin got boring. And ESBL beta-lactamase makes the hospital a real tough place. So honey, don't you touch my carbapenem. Plenty other bugs for them drugs. So if you choose to use my carbapenem, you're not in love with me, you're stuck with CRE. I heard you trying to get your hands on Zosep. You used enough to fill up this old ocean. And Vancomycin as far as the eye can see. So why the hell are you surprised about VRE? Honey, don't you touch my carbapenem. Plenty other bugs for them drugs. So if you choose to use my carbapenem, you're not in love with me, you better call the CDC. You better find yourself another ID. Thank you for listening.